Good morning, all. So today's case, demographic details are, this is a case of a baby N, male. Age at the presentation in our hospital was 6 weeks, resident of Hisar, Haryana. Date of admission in PGI was 11th November 2022, and date of discharge was 2nd January 2023. Total duration of stay in PGI was 52 days. Chief complaints were cough for 2 days, difficulty in breathing for 2 days. This presentation was 25 days before the presentation in our hospital. History of present illness: cough was intermittent, gradually increased in intensity. Breathing difficulty in the form of increased respiratory efforts. There was history of decreased feeding, history of lethargy, no history of fever, no history of any abnormal body movements. Antenatal history was uneventful. Antenatal ultrasounds were normal. Birth history: child was born on 30th of September. Full-term normal vaginal delivery, 3,500 grams AGA, cried immediately after birth, and the course was uneventful. Immunization history: child was given the immunization at birth. Postnatal history: on 16th day of life, child developed cough and difficulty in breathing and was taken to local private hospital, and where the child got admitted. So outside treatment history: so at birth, child was well. On 16th day of life, developed cough and breathing difficulty. So taken to local hospital after 2 days, where got admitted, and the treatment was given in the form of mechanical ventilation, inotropic support, anti-CCF drugs, and IV antibiotics. So 2D echo was done, and it showed large ostium secundum ASD of 11 mm, large anterior muscular VSD of 9 mm, and both having left to right shunt. Okay. So their child remained for 3 weeks and then referred to PGI after 3 weeks of treatment due to unable to wean off from the mechanical ventilation. So at emergency in triage, on initial impression, the appearance was abnormal. Child was hypotonic on IPPR, and circulation was normal. On primary assessment, airways was cured, tube was in situ. On IPPR, on chest examination, bilateral clefts were present. SpO2 was 98%. Heart rate was 160. Perfusion, peripheral and central, both were normal. BP and upper and lower limb were equivalent and normal. So state-to-state variability was poor. Tone was flaccid. On exposure, child was afebrile. Pallor was present, and 5 centimeter liver was palpable below right costal margin. So these are the BP readings in upper and the lower limb. They are equivalent and they are within normal limits. So on anthropometry, weight and length, Z-score was -3, head circumference normal. On systemic examination, the significant findings were in CVS, on inspection, precordium was hyperactive. On auscultation, pansystolic murmur was heard in left parasternal area. In respiratory system, on auscultation, bilateral clefts were present, and per abdomen liver was palpable. Span was 9 centimeters. And in CNS, state-to-state variability was poor, and the tone was decreased. So this is the X-ray. It is a little rotated, but cardiomegaly is visible. And in lungs, there are opacities and increased pulmonary venous congestion. So database: 6 weeks old boy with acute respiratory illness presented in respiratory failure. On examination, had bilateral clefts, pansystolic murmur, and hepatomegaly. So syndromic diagnosis was acyanotic congenital heart disease with increased pulmonary flow, likely possibility of VSD, with congestive cardiac failure, with sepsis, pneumonia, and failure to thrive. So child was admitted in emergency, and the management was done. For airway and breathing, IPPR was given. For circulation, IV fluids were started, 60% maintenance fluid. For CCF, furosemide was given at the rate of 2 mg per kg per day, and for sepsis, injection meropenem was started. Within 24 hours, child has the episode of accidental extubation, resulting in desaturation and bradycardia, for which CPR was done, and there was a return of spontaneous circulation. So child developed shock after that, so for which the ADR infusion was started. So the also developed this hypoglycemia. Investigation showed raised LFTs, so possibility of ischemic hepatitis was kept. So for this, acute liver failure measure was taken. And after the shock was corrected, ADR was stopped and the furosemide was started again. So 2D echo was done in the emergency by the cardiologist. So it showed severe coarctation of aorta with mild left ventricle dysfunctions, with severe PAH, with ostium secundum, ASD and VSD, with ASD of 7 mm and VSD of 6 mm. It was vascular VSD. So CT angio was done and then CTVS opinion was taken. So on just before 17th of 11, 6th or 5th day of admission, child was given extubation trial and was put on CPAP, but there was a failed effort and the child was again reintubated. So these were the investigation. TLC were on the higher side. There was thrombocytopenia. CRP was raised. And in metabolic profile, the urea was a little on the higher side and SGOT-PT were raised. So the high values of the SGPT and episode of hypoglycemia, the ischemic hepatitis were kept as a possibility. Then CT angio report. I would request Dr. Shreya, is she here, to please explain us about the CT angio.
Here, limited sections of contrast thoracic angiography are provided. On seeing the whole scan, the patient had situs solus, there was levocardia, and the looping was maintained. In the first image, we can see that there's a large ostium secundum ASD. On the first image, we can see that there's a large ostium secundum ASD. The pulmonary artery confluence is maintained and the pulmonary artery appears prominent. It was measured to be 1.05, which is on the higher side. The pulmonary artery and the confluence is maintained and the pulmonary artery appears prominent and which was measured to be 1.05, which is on the higher side for the age group. And on the coronal section, we can see the aorta is arising from the morphological left ventricle. And we can trace it here that the aortopulmonary relationship is maintained and there is no evidence of a truncus arteriosus or a common outflow tract. On sagittal sections, we can trace that the arch is complete and there is no evidence of interrupted aortic arch between any of its branches. Further down, we can see that there is a focal area of constriction in the descending thoracic aorta, distal to the origin of the left subclavian artery. However, no collaterals can be seen at this point. The constriction was measured to be 0.19 centimeters for a segment of 0.45 centimeters. There's also a patch of consolidation in the left lower lobe. We can also appreciate in these sagittal sections that there is no common connecting channel between the pulmonary artery and the aortic trunk to suggest any patent ductus arteriosus. So the findings, since there's no interruption of arch and there is a clear constriction at the level of descending thoracic aorta, which on further sections was seen to continue into the abdominal aorta beyond the diaphragmatic hiatus, the findings of coarctation of aorta was given on the report.
Thank you, Dr. Shreya. So the final report was ASD of 8.7 mm small muscular ventricular septal defect of 1.9 mm, 4.3 mm long segment of aorta shows narrowing 11.3 mm distal to left subclavian artery. No PDA was seen, and final impression coarctation of aorta with aortic arch hypoplasia with atrial and ventricular septal defects. So now the child got shifted on 17th of 11 for the further stabilization and management. So at receiving, child was intubated on IPPR, saturations were 98%, bilateral clefts were present, and circulation was normal, perfusion was normal, BP is, as shown in all limbs was equivalent and with the normal limits, and infusion of midazolam and fentanyl was going on. Child temperature was normal, and RBS at that time was 78, and liver was 4 centimeter. So in HDF, child got treated for the respiratory failure, was put on PRVC mode with FiO2 of 40%, tidal volume of 24, PEEP of 6, and respirator of 40. For CCF, infusion of furosemide was started, and sepsis injection meropenem was continued. Child was given PRBCs in view of anemia. So the ventilator settings were tapered off till FiO2 was 21%. Other things we could not taper off, so child was not able to wean further. And for CCF, infusion was shifted to the oral furosemide. For sepsis, we did LP, which was non-meningitic. So review CTVS consultation was taken, and it was advised for the medical optimization followed by surgery. So these were the investigations. HP was 10. So since the child had congenital heart disease and on ventilator supports, we transfused here. So TLC were high, but CRP started decreasing, platelets starts improving, and ProCal was 1.9. So in metabolic profile, lefty started improving. And so renal function tests also improved. So at this time, the diagnosis was acyanotic congenital heart disease, that is severe coarctation of aorta with AST, VSD, with congestive heart failure, with pneumonia, and with difficult weaning from positive pressure ventilation. So congenital heart disease accounts for nearly 28% of all major congenital anomalies. The birth incidence of congenital heart disease is estimated at around 8 in 1,000 live births worldwide. So acyanotic heart disease are divided in two categories. One is lesions with increased volume overload with left to right shunt, that is AST, VSD, and PDA. And lesions, second is the lesions with increased pressure overload. So in this, one is obstruction to the ventricular outflow, that includes pulmonary stenosis, aortic stenosis, and coarctation of aorta. And second is obstruction to the ventricular inflow, that is tricuspid mitral stenosis, partial obstruction to the pulmonary veins. Now, VSD is the most common congenital heart disease in the infants and children. 25% of all the congenital heart disease. VSD may also accompany other congenital defects. Most of these close spontaneously in childhood. Spontaneous closure of muscular and perimembranous VSD can occur during first 6 months of life. 60 to 80% of small to moderate muscular VSD close spontaneously by 8 years of age, and 35% of small perimembranous VSD close spontaneously by 5 years of age. So classification of VSD, one is based on the location of the defect. So there are 4 types. Type 1 is subarterial, type 2 is perimembranous, which is the most common type and seen in 80% of the cases. Type 3 is in inlet, and type 4 is muscular. And based on the size, it is large, moderate, and small. So that is the size of the defect when compared to the aorta, aortic orifice. So pathophysiology of VSD with large left to right shunt. So at birth, in large VSD, pulmonary vascular resistance remain elevated and delaying normal postnatal decrease in pulmonary vascular resistance. Thus, the shunt magnitude may be limited initially. So with time, normal involution of media of small pulmonary arterioles occurs, and this leads to decrease in the PVR in first few weeks. So thus, the magnitude of the left to right shunt starts increasing. So thus, the clinical symptoms, becomes apparent. In moderate to large VSD, children usually present with the delayed growth and development, repeated pulmonary infections, and features of congestive heart failure, that is fatigue, sweating, rapid breathing, and feeding difficulty. So management includes medical management, that first is controlling the congestive cardiac failure by giving diuretics to decrease the preload, and for decreasing afterload, we give ACE inhibitors. Then hemodynamic monitoring, electrolyte optimization, treatment of infection, correction of anemia and micronutrient deficiencies, and nutritional optimization. So surgical treatment, it is done in the cases where there is medical treatment refractory CHF for infants between 6 to 12 months of age with moderate to large VSD to prevent the pulmonary vascular changes. Now, in patients more than 2 years of age with QP-QS ratio more than 2:1, and patients with supracrystal VSD of any size. So then is the coarctation of aorta. It accounts for 8 to 10% of all the congenital heart disease, with an approximate incidence of 4 in 10,000 live births. It is seen more in males and is commonly associated with other cardiac and extracardiac anomalies. Usually, a narrowing is in the region of ligamentum arteriosum, and there are two anatomic types, that is preductal and postductal. So this is the figure showing. So in first figure, the narrowing is seen before the start of PDA. So this is the narrowing which is before the PDA, and in the postductal, the narrowing is after this remnant of the PDA, that is ligamentum arteriosum. So these are two anatomic types. So clinical presentations. So here we'll be discussing the presentation of the neonates. In the mild coarctation of aorta, the children are mainly asymptomatic, but and usually the diagnosis is missed. On physical examination, if we do, we'll find the absent or delayed femoral pulse, systolic murmur, and in severe coarctation of aorta, neonates usually present in heart failure and shock. The signs and symptoms would be pallor, irritability, diaphoresis, dyspnea, and hepatomegaly. And there will be disparity of BP and pulses in upper and lower limbs, and bounding pulses of arms and weak pulses of lower limbs, but this will be apparent after controlling the shock part. In the severe coarctation of aorta with large PDA, differential cyanosis will be seen. So on chest X-ray in symptomatic infant, there will be marked cardiomegaly, pulmonary edema or pulmonary congestion. So in this case, the findings which were in the favor of coarctation of aorta was signs of congestive failure, but there was no disparity of pulses and disparity of BP in upper and the lower limb, even after the shock part is controlled. So management of severe coarctation of aorta includes the medical management, where the prostaglandin infusion is started to promote the ductal patency and establish the flow to the descending aorta and the kidney. So anticongestive measures with inotropic agents are given, and the medical stabilization followed by surgery. And surgery includes surgical repair, that is resection and end-to-end anastomosis, and second is a balloon procedure. So at this point of time, the child we tapered the mechanical ventilation setting to FiO2 21% and volume of 24, PEEP of 5 and rates of 35. For CCF, we continued furosemide at the rate of 4 mg per kg per day. Sepsis part was passive, and nutritional and medical optimization was done. And child was stabilized, followed by shifting to CTVS unit for surgery. So for before shifting, we did the pre-surgical workup. Pre-anesthetic checkup was done. Lab investigations were sent, CBC, metabolic profile, and viral markers. Chest X-ray, ECG, and 3 units of PRBCs were arranged, and child was kept NPO for 6 hours before shifting. So these were the pre-surgical investigations, and they were all normal. TLC came out to be normal, CRP became negative, and metabolic profile was normal. LFTs and LFTs was normal. So RFTs were also normal. So ECG and X-ray was done. And child was shifted for surgery on 26/11/22 on 16th day of admission in the transport incubator and the transport ventilator. So vitals at the time of shifting were normal. For this, I will like to call Dr. Nitish.
Good morning, everyone. So the patient was shifted to us on 26th of November 2022 and was planned for surgery. Patient was induced under GA and we routinely do a on-table echocardiography. On-table echocardiography was suggestive of minimal turbulence in DTA with a peak gradient of 30 mm Hg. And on-table echo also could not reveal the PDA. Other findings were collaborated, that is ostium secundum ASD of 10 mm, good biventricular functions, and there was a small apical muscular VSD. So we put an arterial line in the left radial and left femoral arteries. The left radial arterial pressure was 93/39 with a map of 62, and left femoral arterial pressure was 92/38 with a map of 60. The pressures were identical, and this was one of the indirect evidence that coarctation, if even present, it is not hemodynamically significant. We only consider patients with hemodynamically significant coarctation above 20 mm Hg of gradient in the systolic blood pressure. So we proceeded ahead with the left posterolateral thoracotomy, and we entered via the fourth intercostal space. Incised the parietal pleura, identified the vagus nerve, recurrent laryngeal nerve, and the phrenic nerve, and the DTA. What we could see was there was a large PDA present with a very low insertion on the DTA. So this is the image. Can I have the pointer? So usually the Yes, sir. So usually the PDA would be having nearly a straight course. It is going very, I could not, this is a patient when you are looking the patient from the operating size. Patient is left side, left lateral position. So PDA it is not persistently as per defined, but PDA what we could see was nearly at the level of 6th or 7th intercostal space. This is after retraction. So PDA would have been mostly like here. One, the PDA was not mentioned anywhere, and other is it shouldn't have been coming at this point mostly.
But it was above the level of diaphragm.
Above the level of diaphragm. This is the cranial side. This is the caudal side. This is the PDA. This is the DT. This is the arch. Arch would be over here, containing as DTA, going downstairs, merging with the PDA, and this would be the DTA going downwards, like here. LPA. One of the confusion that we usually have during OT is which one is the PDA and which one is the continuation of the arch. That at times become very difficult because the diameter of both the PDA and DTA is same, nearly same. So what we did was we looped the PDA. This blue vascular sling is with the PDA. This red is with the DTA. Another thing that we did was, usually what we do not do is we sclenetize the DTA completely along the course. Whatever was visible to us, we de-sclenetized it. See, but that means we removed everything, external whatever covering was there, we removed it also over here. We snugged the DTA. We presumed this to be DTA and we snugged it. The femoral arterial pressure nearly fell down to 0. So this was suggestive that this was the evidence that this is DTA. Again we snugged the PDA. The femoral arterial pressure increased by 9. Suggestive that there is the diastolic runoff is decreased. And at that time also there was no gradient, no significant systolic gradient. So we proceeded ahead and we did the ligation of the PDA. This PDA was there when ligated. This DTA was left in situ. This is the net result. We can also see a small lumen in the PDA here. after division of the PDA. This is the coarctation of the, this is probably there would be some kinking over here, might be because of the insertion of the PDA, might would have been coarctation, but there, because there was no significant gradient, it was not further addressed. Patient was then shifted to CTVS PICO. Patient was hemodynamically stable all throughout the course, but patient developed VAP. ET culture on the POD3 was suggestive of Acinetobacter baumannii, sensitive to colistin, and colistin was added. On POD8, Pseudomonas aeruginosa was found in the ET culture, which was suggestive to piperacillin tazobactam, which was further added. There were failed extubation trials on POD8 and POD11, and patient was further shifted to HDF for further respiratory management. Around, sir, at the side of the arch of aorta would be around 5-6 millimeter. It was large PDA, much more than size of the arch of aorta. Yes, sir. No, sir, arch anomalies was not seen. Yes, sir. It was more than, it was a large tubular PDA that we classically say, very large size, because the size of the, all the three vessels are nearly of the same size here. Yes. Patient was shifted on 9th of December to HDF.
Thank you, Dr. Nitish. So after 14 days of stay in CTVS, child was shifted back to HDF in view of failed extubation. So this is a study which is showing that this study was done to see the prevalence, etiology and risk factors for the extubation failure in neonates after cardiac surgery. So in the study, 160 neonates were taken, and out of 156 cases, 25 had extubation failure. And then after first extubation, when the child got reintubated, on subsequent extubations, 17 cases, they were successful. And because of the medical optimization of the causes of the reintubation, and remaining 8 cases needed surgical intervention, including tracheostomy and cardiac surgery. So the multivariable analysis identified airway disease and mechanical ventilation longer than 7 days as a risk factor for the extubation failure. So these were the reasons enlisted in this study. So divided into 4 categories. One is respiratory dysfunction, second is hemodynamic instability, third is upper airway obstruction, and the fourth was gastrointestinal bleeding. In the respiratory dysfunction, so the various reasons were diaphragmatic paralysis, atelectasis, malacia, tracheal stenosis, weak cough, pleural effusion, pneumothorax, respiratory muscular weakness, pulmonary congestion, GER. And among these, diaphragmatic paralysis, atelectasis, and malacia were seen in more cases. In hemodynamic stability, low output syndrome and onset of the sepsis was seen the cause. And in upper airway obstruction, in 4 cases, upper airway obstruction was the cause, in which excessive secretions, vocal cord paralysis, and glossoptosis was seen. So there is another study. It was done to describe the epidemiology of extubation failure and identify the risk factor for its occurrence in neonates undergoing surgery in congenital heart disease. In this, 283 neonates were enrolled, out of which 35 failed their first extubation at median time of 7.5 hours. So it was seen that extubation failure occurred in 12% of the cases, and it was associated independently with worse clinical outcome. And use of uncuffed endotracheal tubes and prolonged open sternotomy were identified as independent and potential modifiable risk factors. So then in HDF after surgery, the child was managed for the respiratory failure. We weaned off the child from the mechanical ventilation and was put on the non-invasive ventilation, pressure support CPAP, on the 17th post-op day, and then shifted to HFNC and was brought to the room here on 32nd day of surgery. For CCF, we continued furosemide and added enalapril. So as there were two microorganisms which grew in the ET culture, colistin was already given, and for Pseudomonas, we added piptaz. Since child was on sedations for long term, so child developed withdrawal syndrome, which was treated with the clonidine and oral morphine, and was tapered off and stopped over the stay. For post-operative rehabilitation care, feeds were given F100 with MCT oil with daily calories of 170 kilocalories per kg per day and proteins of 4 grams per kg per day. Supplements were added, that is calcium, vitamin D, iron, multivitamins according to RDA. Chest and limb physiotherapy was done, and post-extubation nebulization was given. So in general, what all is included in the post-cardiac surgery care. So monitoring, first is monitoring of hemodynamics and labs. Pharmacological cardiac support, which include anti-CCF measures to optimize the preload and to decrease afterload. So inotropes, which includes dobutamine, milrinone, adrenaline. So mechanical ventilation, third is mechanical ventilation. So it varies with the various factors like preoperative state of the child, underlying cardiac physiology, surgical procedures, degree of hemodynamic instability, volume overload. So the target of mechanical ventilation is adequate oxygenation and ventilation. Then fluid management for optimizing preload for adequate cardiac output, prevention of hypoglycemia and maintenance of the electrolyte balance. Then is sedation and analgesia. Usually we give opioids for the post-operative pain management. Fentanyl and morphine infusions are used, and followed by the oral drugs as soon as possible. And the nutrition and feeding, most important part. The patient post-surgery enters a hypermetabolic and hypercatabolic state, so adequate calorie and protein supplementation is required. So final diagnosis was made was acyanotic congenital heart disease with VSD, ASD, and PDA with congestive cardiac failure with the PDA surgical ligation, ventilator-associated pneumonia, and iatrogenic withdrawal syndrome. So discrepancy in this case between preoperative and intraoperative diagnosis. In preoperative diagnosis, it was the investigations were and clinical examination was suggestive of severe coarctation of aorta, ASD and VSD. And during surgery, it was PDA, VSD and ASD. So this is a study to show the discrepancy in the pre-op and intra-op findings. So this is a study to done the comparison of pre-operative transthoracic echocardiography with intraoperative findings in the patients with the congenital heart disease undergoing surgery. So in this case, pre-op TTE correlated with the intraoperative findings completely in 228 patients. So it was correlated in 228 patients. They were false negative in 19 and false positive in 1.2%. So neither the false positive and false negative errors resulted in the complications or adversely affected the surgical outcome. So there is another study. In this case, in this study, 175 consecutive patients were taken. So this was in pre-op TTE versus cardiac cath study. So in this case, from the cardiac catheterization, 49 cases revealed additional data of surgical importance, and in 3 cases, there were different diagnoses. So age at the time of echocardiography was not a significant factor affecting the accuracy. So persistent left superior vena cava, MAPCA, that is main arteriopulmonary collateral artery, pulmonary artery anatomy and coronary artery anatomy were the most frequent cardiac lesions that were missed on TEE, but were found on the cardiac cath study. So incorrect TTE diagnoses were aortopulmonary window, PDA, and vascular ring. The third study was between echo and CT angiography. So 45 patients who underwent preoperative echo and CTA assessment in the intensive care units were included in this study. Imaging methods were compared for diagnostic accuracy, sensitivity, and specificity, while surgical findings were accepted as a gold standard. Both methods were highly sensitive and specific in identifying the anatomy confirmed during the surgery, and additionally, CT angiography was useful as a complementary imaging method along with the echo in the assessment of the extracardiac vascular structures. So at discharge, the child was on room air. Vitals were stable with heart rate of 130, respiratory rate of 42, normal work of breathing. Pulses were normal in volume and equivalent in all limbs. Child was accepting orally well and was discharged on medication supplements, iron, calcium, multivitamin as per RDA recommendation. Oral furosemide at the rate of 2 mg per kg per day. And follow-up status after 2 weeks of discharge, weight gain was present. So take-home message, management of complex congenital heart disease needs a multidisciplinary approach. Successful outcome in the patients of CHD undergoing surgery depends on optimal preoperative cardiovascular evaluation, preoperative stabilization, and post-surgery care. Rarely, intraoperative findings may differ in respect to preoperative diagnosis of congenital heart disease. So, thank you.